So week 7, after an exam, we are just going to do a Cahoots. I've looked at this Cahoots really closely, and I've made, quite a few changes in it again, just trying to make sure that you have all the concepts that you need that can help you. So as I describe these things, if you're not understanding, stop me so I can help explain it to you so that you are getting what you need to know about it. No, I did send you the PowerPoints. You do have them. So if you go back and look at the PowerPoints with the Cahoots, some of the answers are there also. And in those PowerPoints, I love to put pictures, and I really take time putting pictures there that do tell quite a bit. Doesn't they always say that? Doesn't a picture tells 1,000 stories? Well, I believe it. So I make sure that you do have pictures that really do explain things. All right, we're just going to get
Professor,
going.
hold me 1 second only, please.
Okay, go ahead.
Thank you.
Not a problem. Ulamar likes to win, so be careful, guys. She's after you. Okay. There we go. All right, let's get going. Week 7, cerebral and endocrine, big topics, okay? Growth hormone is administered by what route? Now, when you talk about the pituitary gland, part of the pituitary gland has to do with growth. And we monitor the growth by what? Measuring height and weight, seeing if they're growing where they should. Well, some children are very small, and sometimes you want to get them, a bigger chance. I know one of the nurses I worked with, daughter was very small, and she was placed on these growth hormones. They are a subcutaneous injection. It could be daily, weekly. It all depends on what you get and your physician. But this is something that the parent really has to pay attention to because it is an injection. And it does work. And how do we know it works? We can measure how tall they're getting. And we give it until they stop growing less than an inch a year. And that's when we stop the growth hormones. Highest priority for a patient diagnosed with syndrome of inappropriate anti-diuretic hormone. Well, if you have an inappropriate against urinating hormone, anti against urinating, that means this hormone is making you not urinate. What are you really going to be watching? Yes, intake, output. We're going to be watching daily weights, because if you're not urinating, what's happening? You're going to be keeping the fluids in. You're going to be gaining weight. Probably blood pressure is going to go up. You're going to see swelling, but we're going to, that intake and output, we really want to monitor. These children will be on low intake, just a little bit per day. Also salt, be watching salt, and we're going to be watching blood pressures too, because all that fluid, and then we'll go into congestive failure. So think of what fluid would do to the body. Which of the following are signs of a syndrome of the inappropriate anti-diuretic hormone? What are you going to see? It's inappropriate anti against diuretic, against urinating hormone. What are you going to see? And it's against urinating, right? Anti-urinating, anti-diuretic, which means you're not going to have urinary output. You're going to be retaining it. And then all of those things you see with urinary retention and holding on to fluids, the swelling, the congestive failure, high blood pressure, all of these things you will see with this syndrome if we do not get this child urinating, whether it's an adult or a child, same thing. Got to get them urinating. What is important to cover when teaching the family about polypropyl? It's also called PTU, is one of the things, and it's for the thyroid gland, and it's given for hyperthyroidism. It's a medication that was covered in pharmacology. I know because I taught pharmacology at one point. And it's one of the things that we need to teach our parents. And what it is PTU, this polythyroxyl, has a side effect of having a lower white count. So they are at risk for fevers and sore throats. So if we see this child having chronic sore throat infections and fevers, this is something related to the medicine. So the physician needs to know about that, okay? An initial sign of diabetes insipidus. The posterior pituitary gland secretes a hormone, and sometimes it secretes too much. And we're going to see it's actually the 2 Ps. Is polydipsia, polyuria, which means you're thirsty and you urinate a lot. We know diabetes is you're thirsty, right? But diabetes insipidus is the urine with the taking the fluids. What's interesting in infants, you can give them their bottle and they're hungry and crying and crying. You give them a bottle of water, they're satisfied. In diabetes insipidus, it's one of the ways we diagnose these young infants, usually the newborns. Multi-select. What are the clinical manifestations of juvenile hypothyroidism? It is just like adults, same symptoms when you don't have enough thyroid hormone, except for one difference. So dry skin, the hair gets thin, constipation, cold intolerance. But in children, it also is related to the growth. So as we're doing, as they come into the doctor's office, ER, urgent care, first thing we do is we weigh a child and see how tall they are. So we're keeping a record of it. If we're starting to see they're not growing, it could be due to not enough hormones being given in a supplement. Because usually by then we will know that the child is hypothyroidism. So maybe they need more. A child has had a simple febrile seizure. What education would you provide the parents? Now, febrile seizures are probably the most common of all seizures that we can have. And it is due to a temperature that all of a sudden appears in 20 minutes. Normal temperature, 20 minutes later, they have a high temperature and the brain goes and can't understand it. And they have a seizure. Now, one of the things with any seizures, all you need to do is protect them, safety. If they're having a seizure and that, let's say they're in the hospital with you, you put the head of the bed down, maybe pad the side rails, maybe turn them on the side if you can in case they vomit. Any objects that are sharp and hard that could injure them in the bed, get rid of them, okay? So there's not much you can do, but we can protect them. So it's safety is what we do most for these seizures, whether it's a tonic clonic or whether it's a febrile. What type of seizure? Is it when the body's jerking, you're foaming at the mouth, and this child is rendered unconscious? This is different than the febrile seizure. In fact, I just mentioned it. When you think of seizures, this is usually the one that you think of. The arms and the legs are just jerking and they're foaming and they're unconscious, and they wake up and they're like the postictal, they don't remember what happened, and keep asking the same questions. Tonic clonic, most common of all those seizures, the type of febrile is the most, But in a child who has seizure condition, tonic clonic is what we mostly see. After a fall, what assessment would be considered a neurological emergency? I'm talking of the fall maybe from the first story of a house, off of a ladder, onto a cement floor. Your head hits the ground. When you see this, this is really an emergency that needs immediate surgical intervention. And that is when you see A, which means one pupil is dilated. But not only they're big, light doesn't react to them at all. I mean, that's one of the things that says there is so much pressure in that head, and usually they need to go in and drain the blood because usually it's blood occupying space, and they have to do that and get rid of that fluid now to protect the brain so there's no permanent injury or disability. With a patient with a head injury, the signs of increased intracranial pressure include, so you get a child, they've fallen or they've hit their head hard, and they come in and they're going to change your assessment of them. Just their neuro assessment is going to change. Which one is showing you increased? Well, they start in there, they're talking to you and they're answering questions, and then all of a sudden they start to get a little lethargic, or they're asking that same question over and over and over again. Another thing that shows increased intracranial pressure is if they're vomiting, not related to any food or anything. This is the same thing you would see actually with brain tumors. It's like when you see that pressure is building in the brain because that tumor is getting bigger. So headaches that get more and more and more, and vomiting not related to eating. This is really signs of intracranial pressure and that restlessness that goes along with it. What notable sign may indicate increased intracranial pressure in an infant? Now, you would see maybe vomiting, but what's that one thing that you will know something's going on? And it's a bulging fontanelle at sleep, not when crying, okay? But they change their cry. And it's like put nails on a chalkboard. It's this high-pitched cry. As a nurse, when you learn it and you've heard it, and you walk into a room with a child who has a neuro issue going on, and they cry, you're going to say this kid is neuro. It is a very high-pitched cry. I mean, you might see, the veins in their head start to pop. Fontanelle will be big, just laying there with absolutely no movement. So those are things. And of course, the pupils will be part of it too. But that high-pitched cry, that's number one thing I would hear. All of the following increased intracranial pressure except what? Well, we're going to be taking care of children, adults that are going to have increased intracranial pressure for many reasons. So we need to know how we decrease the amount of pressure we exert on this, client. So whenever we touch a patient, whether it's a child, whether it's an adult, we're turning. If they're coughing, you're suctioning. But the change in heart rate does not affect cranial pressure at all, okay? That does not affect cranial pressure, but turning them coughing, suctioning, all do affect intracranial pressure. Which of the following signs and symptoms are more common in children than adults following a head injury? So one of the things children do, they're going to vomit. Adults take a lot more to vomit. So a child who is vomiting, you're going to suspect a head injury, especially if their head was hurt. In an adult, that's not what you're going to see. You're more looking for how alert they are, their pupils, and their orientation is a big thing, and headache and a pupil reaction. But in children, you're going to see that nausea, vomiting getting worse and worse as the pressure gets bigger. What medication may be used for a child with cerebral edema due to a fall? Well, cerebral edema, fluid in the brain. What is used for fluid in the brain? And that's your mannitol. Furosemide is peripheral, congestive failure, your lungs full of fluid, but specific for the head up is the mannitol isotal, okay? So mannitol is what we use. It's a quick get rid of fluid out of the brain. It works extremely fast and well. It's not your furosemide. Ray's syndrome, what's that? It's one of the reasons why we don't give this medicine to children. It's because it can be caused by aspirin. It is a metabolic disorder. It occurs in children mostly. So that's why the only thing we give aspirin for in children is we're going to be giving it for your Kawasaki disease. And sometimes we use it in some cardiac syndromes, but we use it sparingly. Febrile seizures usually occur in, well, we know febrile seizures we usually grow out of, right? So the patient is somewhere between 6 months and 6 years. My first grandson had a febrile seizure. He only had it one time, and the mother carries around a thermometer and medicines in her purse all the time. I think every day this kid still gets his temperature taken 16 times. I mean, she's a little obsessive, but never has had another seizure. And they do grow out of it, thank goodness. Childhood hypopituitarism results in which condition? Excuse me. The pituitary does secrete growth hormones. And when you don't have enough, you're going to be small. And it could be that dwarfism could be part of it. How would you describe precocious puberty? I mean, we know all children go through puberty in some manner or form, but precocious is what? It means it happens too early. I mean, you will see young 6-year-old children, little girls with breasts already, or even hair on the face on boys. You can see full beards on them. And that is the puberties coming on too quick. We can hold it off. There is medicine we can do to hold it off until there's a time where they should go through puberty. But can you imagine being that poor little 6-year-old girl who's having breasts and the teasing that would happen? So we don't want that to go on. Signs of hypothyroidism? I told you, it's just like adults, except for the growth. So intolerance to cold, dry skin, sparse hair, yes. Very important that children diagnosed with hypothyroidism, especially at birth, that they've given the supplements, your Synthroid, the levothyroxine, because it has to do with cognition and being mentally alert and growing properly. And part of it is that mental. So what would we see with an infant born with hypothyroidism? It's one of those things where they won't stool. They can be constipated, right? So they don't have a stool within the first 2 days. And that's one of the things we look at. They don't stool, we will be checking them for thyroid problems. A multi-select. What lab values are important to monitor with a child with congenital hypothyroidism? So we're going to be monitoring their T4 and their TSH. If the T4 is low, the TSH is high. If the TSH is low, the T4 is high. So we need to look at them and that they're in the proper way. And there's different medicines for each level being low. So we need to watch it. Growth hormones is, a pituitary thing. It's not a thyroid. And cortisol is adrenal glands. It's not a thyroid.
And I know that.
How can you monitor a child with hypo or hyperthyroidism? What did I tell you what they look at and those signs and symptoms of hypothyroidism and how we measure if our medications are effective? It's as simple as we do every time a child goes to the ER, urgent care, doctor's office. We're going to get a height and a weight, making sure they're growing that the way they should, because thyroid gland does have some input into growth. I mean, you're an adult, you've done growing. That's why it doesn't affect it. What acid-base alteration would you see in a diabetic child with Kussmaul respirations? Well, if you're in Kussmaul's respirations, you are in a metabolic acidosis. So your body's saying, I need to correct that metabolic acidosis. So we're going to do completely the opposite, right? If it's metabolic, we're going to do something respiratory. We have acidosis, we want to make it alkalosis. So respiratory alkalosis. Does that make more sense to you with an acid-base problem? So your body loves to correct what's wrong, so it does the opposite. If it's metabolic, it goes respiratory. If it's acidotic, it's going to go alkalotic, okay? And you will see at least 4 questions on your HESI regarding acid-base. So this is why I'm pulling them in here for you to see it, to try to understand it. If you don't, meet with me. I'll teach you. Multi-select. What would a child with Cushing's syndrome look like? So you are going to see a child, their extremities are skinny, but they're big and round and a big pendulous abdomen, and they're going to have hair growing, those red ruddy cheeks you see. It's weight gain. It's not weight loss. Cushing has to do with cortisol, steroids, whether it's given from what our body has inside of us, or if we're giving steroids like prednisone for a long period of time. And that's Cushing syndrome is too much steroids for too long of a time. Seizures in children most often are the result of so febrile seizures are that abrupt rise in a body temperature, okay, which means you were normal. 20 minutes later, you're 102. And that quick rise, that brain goes, zoop, 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 I don't get it. And you go into a seizure. A multi-select. You walk into a child's room with a fever of 104.6 and you see them having a seizure. What can you do? So you're never going to give a cold water bath because you're basically going to shock their system. All you can do for a seizure is to protect them, right? Turn them to the side. If you can, pad the side rails. And then if there's anything in the bed, protect them, anything that can hurt them. Autoimmune disease of the thyroid gland. These are usually females, and they're usually adolescents that we end up diagnosing them. My sister-in-law, my daughter-in-law has this. And it's called Hashimoto's disease. Now, Hashimoto's is autoimmune. There's nothing you could do. You can't remove the thyroid. You will be on thyroid hormone replacements for life. And they're always being regulated because, you know, stress and all of those things do affect the amount of hormones that you need or don't need. Addison's disease, what is that? So now we're talking about adrenal gland. We have Cushing's, then we have Addison's. So as Cushing's is too much, Addison's not enough. And it is a condition where these children will be getting cortisol and aldosterone as part of their treatment. And in times of stress, they're going to need more so that they would get extra doses to try to get them over that period of time that they need it from. So Addison is not enough. Think adrenal, always think cortisol. Multi-select. Ventricular peritoneal shunt. Now, many children are born and their fluid in their head, the cerebral spinal fluid, gets clogged up and they get something called hydrocephalus. And it's going to swell and swell that brain, and we don't want that pressure there, but it's going to be continuous. So what they do is they put a tube up into the ventricle in the brain. It goes behind the ear, and this tube goes down into the peritoneum. And there's like a little pump thing behind the ear. We do not touch anything. But what we'll do is measure head circumference, measure abdominal girth to see if the head isn't too big or the abdominal girth. But it will have a constant little drip of cerebral spinal fluid to keep that head from getting too much pressure. Ventricular peritoneal shunts are something that as they get bigger are going to be changed. And one of the signs that we see on a child with this VP shunt is if they're vomiting and headaches, something's going on, it's a shunt malfunction, and maybe it's disconnected or they need replacements. A common side of Graves' disease includes blank or protrusion of the eyes. And this again is hyperthyroidism, that we're going to use that prolipropyl or that PTU medicine for, which causes leukopenia. And it's called exophthalmos. It's those big eyes. Have you seen the commercial on TV that there is medicines now and the lady has sunglasses on and she keeps taking them off, but her eyes are, you know, she's covering her eyes because she doesn't want anybody to see how they stick out of her head. You know, they're embarrassing. So it does work. Another multi-select. What are signs of hyperparathyroidism? So right next to the thyroid is a parathyroid. They have completely different functions. We know the thyroid is all about thyroid hormones, but the parathyroid regulates a mineral in the body. It takes care of calcium, okay? So parathyroid, think of calcium. Remember, calcium, magnesium both work with muscles, okay, too little calcium magnesium, you're going to see this either numbness or twitching, pain in the muscles, cramping because of lack of calcium or magnesium. So parathyroid's all about calcium. So you're going to see that nausea, the vomiting, confusion, and of course the paresthesia in those extremities. How do we treat this? Usually it requires a surgical removal. Now, if it's hypocalcemia, we give a calcium replacement. I'll multi-select. Hypoparathyroidism has signs of technic muscle contractions and what? Remember, it's all about not enough calcium. And it's about that muscle weakness, tetany, and low calcium. Vitamin D is for the joints. It's something completely different. It has nothing to do with the parathyroid. So remember, think of those muscle contractions and paresthesia, etc. And then what do? Let's give some calcium. Doesn't Tums have calcium in it? Sometimes we pop a Tums. What does the parathyroid hormone do? I've told you about 5 times already. You know now. Has to do with regulating the calcium. Excellent, good. Which of the following might be a cause of an adrenal crisis or Addisonian crisis? So when we talk about an adrenal crisis, is all of a sudden you take the steroids and stop them. That's why when we give steroids, there's always a tapering off. If you ever had a Medrol dose pack, starts with 6 or 7 pills down to 1 because we are preventing that adrenal crisis. I'll multi-select. Cardinal signs of diabetes insipidus. Polydipsia, polyuria. Polyphagia has to do with eating and not being able to eat. Remember, diabetes insipidus is a posterior pituitary gland secreting a hormone that's making you thirsty and urinating a lot. A multi-select. Congenital hypoplasia parent teaching should include what? So we're talking adrenal hypoplasia. What does the adrenal gland do? It also secretes like sex hormones, right? It's part of it. So if we don't have enough sex hormones, what would we see? Well, we're going to see a child with maybe having a vagina and a prominent clitoris, which could be a penis, or have a penis and doesn't have testicles, but a vagina. There, you'll see different things. So then we need to assign, is this a boy or girl? And they will be infertile. They will not be able to have children. And because again, it's a adrenal hypoplasia or not enough adrenal hormones, we'll be giving those cortisol and aldosterone replacements. I've seen one in my career. And it was a prominent clitoris with a vagina. And even the labia looked almost like testicles. What causes type 1 diabetes? Aren't you studying this in med-surg too? When you think of diabetes, always think of the pancreas and talking about the pancreas, the islets of Langerhans just don't work the way they should, right? They're being destroyed. It's an autoimmune disease. So you don't have enough insulin being secreted. And you need insulin to do what? To be able to digest carbohydrates. Which statement about a pheochromocytoma is correct? This is an adrenal tumor. And this is an extremely difficult tumor to diagnose. And the problem with this pheochromocytoma is that every now and then it squirts out this catecholamine, which increases the heart rate, increases the blood pressure, maybe cause chest tightness and dizziness, but it's sporadic. And it's hard to catch it from happening. Now, if I'm a nurse and I have a patient being admitted with this, and I'm going to, if they tell me any of these symptoms, I'm going to take a blood pressure right away. I'm going to listen to their heart rate because I want to know what's going on with this. Because it's catecholamine, it's sympathetic, everything up, 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 up on these children. A multi-select. What action should the nurse implement in the care of a patient with a pheochromocytoma? So remember, it's an adrenal gland tumor. It has nothing to do with sugar and it has nothing to do with weight gain. It's all about it secretes a catecholamine. Blood pressure's up, heart rate's up, maybe tightness in the chest, dizziness, has nothing to do with weight gain or blood sugars at all, okay? So it's just like giving epinephrine, a shot of epinephrine. That's what it's like, very similar. Multi-select. Nursing care of the unconscious child include. You know, and basically we're going to do almost everything. You know, if I had to go back and rechange it, I would actually put in pain control there too. Unconscious children show you they have pain by many ways, and it could be their blood pressures go up or heart rate goes up. You might see it. But the unconscious child, we have to monitor them closely. The biggest and the most priority is strict I&O, because we don't want, it's usually due to head injuries. We don't want extra fluid in the head, which could cause more problems. Symptoms of diabetic ketoacidosis are. So remember, when a body does not have insulin to digest sugar, it gets hungry. And it says, okay, I can't eat sugars. What else do we got here in the body? And it says, you know, I've got some proteins I can eat. So they start eating proteins, and proteins byproducts are ketones. Now, but the sugar is still there. You could have blood sugars of 600. I've seen 1,100, the highest one I've seen. So you smell the sugar on their breath. It actually smells like a rotten peach. Put a peach into a Tupperware container and let it sit in a refrigerator for a month. Pull it out and open it, and that rotten peach, that's exactly what DKA smells like. So fruity breath for sure. They're going to have high blood sugars and ketonuria. And we know they're going to be metabolic acidotic. I think the lowest pH I saw with a DKA was 6.88. The child came back and the child did okay, but that was extremely dangerous. That acid was burning that child's brain, if you think about it. A multi-select. An adolescent with a BMI above 95% has been urinating a lot, What test can you anticipate the doctor doing? What do you think is going on here? What makes sense to you? So we know that they are, 95% BMI. So we know they're a bigger child, okay, an adolescent. And then they're urinating a lot. Well, I didn't say also thirsty because that would have given you the big clue. But yeah, we're going to check a urine just to be sure. We're going to see probably, the glucose there, but a hemoglobin A1C is going to be exactly what's going to tell us maybe this child has diabetes. Diabetic ketoacidosis is caused by, I just described all of that to you. So what did I say? So they don't have any insulin, which can't eat the sugars. So they're going to go to somewhere else for the energy, which is proteins. Okay. It has nothing to do with too much insulin because insulin is taking care of sugar. So absolutely not. And it does not cause release of ketones. It's the protein digestion. And ketones, poisonous? Well, it can cause acidosis. And it's not the most common in type 1 diabetes. I mean, it's not common unless your diabetes is not treated. And what do we treat? How do we treat diabetic ketoacidosis? Well, number one, we give a bolus of normal saline, monitor the blood sugars and electrolytes, and we'll be given some IV regular insulin in a slow drip. That's simple as we treat it. Get the blood sugar down. Multi-select. A child with blood sugar of greater than 600, large ketone in the urine, your priority intervention is what? What's the first thing I said to do? We're going to give that IV bolus of normal saline, and we're going to titrate that regular insulin drip according to their blood sugars, and then after all of that, the priority is IV and insulin. The rest, giving the electrolytes, that's after we get that blood sugar down. Can't do anything until the blood sugar gets down. A diabetic child is complaining of feeling jittery and the blood sugar is 45. What's the best treatment for this child? Treatment always depends on patient condition. This child is complaining of feeling jittery. So they're awake, they're alert. They can tell you they're complaining. So yeah, skim some orange juice, even a glass of milk if that's what you have, and that will take care of the low blood sugar. Your patient has experienced a head injury. What would most concern you? Think about this one. Head injury, increasing pressure going on in the head. It's that decreasing urinary output because, what are they pushing on in the head? And if we're seeing that decreased urinary output, we know that this child is getting some pressure in there and we need to relieve that pressure. Get that urinary output going again with some mannitol. Multi-select. How do you detect ketoacidosis? So we're gonna have elevated blood sugars, ketones in the urine, and 4+ glucose. You see all those things, we know that you're definitely diabetic ketoacidosis. Now, if you pull a blood gas, you're gonna see the acidosis there also. The pH is gonna be probably below 7. Select. What would alert you that a child's head injury is deteriorating? Again, it's getting worse. How do you know it's getting worse? So they're difficult now to arouse. They're becoming restless. I mean, a headache, okay, but getting worse headache. And then becoming more confused. It's that process of getting there. When they're confused, they've already deteriorated. So the beginning parts, getting hard to arouse. They're becoming restless. A child's been diagnosed with bacterial meningitis. What is the nursing priority of care? Your kid has, this raging infection. What's the number one thing this child needs? And that's antibiotics. Give them as ordered. Don't be late because, this is a really dangerous thing where, they could have symptoms and complications from having bacterial meningitis. What is the primary cause of injury with submersion? Drowning. I live in South Florida and, I've seen many a drowning in my career. I've seen good outcomes and I've seen bad outcomes. But what's that primary cause? What's that injury? Has also to do with fluid in the lungs, which means no oxygen's getting to the body. So it's a hypoxemia. All the rest could be there, sure, but it is lack of oxygen because they're not breathing, they're underwater. And last question, I'll multi-select. Which CSF lab results correlates with bacterial meningitis diagnosis? Well, the first thing I see is a cloudy cerebral spinal fluid. It should be clear. Once I see cloudy, I'm going to wait till that lab test comes up and I'm looking for 2 different things, which is absolutely going to tell me it's bacterial. And it's going to be low glucose because bacteria love sugar. So it eats it and it throws away protein. So protein's up. And you're going to see elevated white counts. That's usually what that white cloudy color is from. So if you ever have bacterial meningitis and you want to know what to look for, there you go. Low glucose, high potassium. Number 3, C. Number 2, Liz. And number 1, Lamar. You see, we had to wait for her. That's why she loves to win. Z and Mac, good job, guys. Sign your attendance attestations, please. So you get that done. Don't forget about it. So I will be having your grades out. They're not going to be out till 12/1 on Saturday, the final grades. But if you're having a moment, please just send it to me as a message in Canvas and I can give you. Tomorrow, if you want, Zachary, you can ask. I'll send it to you, okay?
Thank you.
Back to Dean, I told him he can give it to you. So it's not a problem, okay?
Awesome. Thank you so much.
No, you're very welcome, guys. Have a great
Professor.
day. No, you're very
Hi,
welcome.
Professor, it's Victoria.